Welcome back to the Deep Dive, where we unpack the critical information from your source material to bring you the clarity you need. Today, we're jumping into a really persistent and honestly painful challenge in women's health: endometriosis.
Yeah, and we're starting with a statistic that's, well, it's pretty astonishing, even if it's well known in the field.
Ah.
Endometriosis affects about 1 in 10 patients of childbearing age. And on average, it takes 6.7 years to get a diagnosis.
Almost 7 years. I mean, just think about that. That's 7 years of pelvic pain, of inflammation, of cyclic bleeding, and often feeling like you're just not being heard.
Mm.
When you add up the impact on a person's life, their career, mental health, decisions about fertility, the cost of that delay is it's astronomical.
It is, and it creates this vicious cycle. The symptoms can be vague, which leads to clinical uncertainty, and then that diagnostic uncertainty just fuels more delay. We have to have better non-invasive tools.
And that is exactly why we're doing this deep dive. You've given us some great sources comparing the two main imaging options for diagnosis and planning for surgery: ultrasound, or US, and MRI. So our mission is pretty straightforward. Is one of these better than the other, or is the answer a lot more complicated?
Well, the sources give us the answer right up front, and you're right, it's nuanced. If you look at the overall diagnostic stats sensitivity, specificity for both US and MRI, the numbers are surprisingly similar.
Okay, so there's a big catch there, I'm guessing.
There is. They're similar when dedicated protocols are used by experts.
So if you were expecting some kind of technical knockout, you're not going to get it. This isn't really a battle of the machines. It's a battle of process and people.
Exactly. The choice really comes down to local expertise and, interestingly, the specific location of the disease within the pelvis.
All right, so before we put these two head-to-head, let's just lay a quick foundation. What exactly is endometriosis for anyone who needs a refresher?
So the simple definition is it's tissue that's like the lining of the uterus, the endometrium, but it's growing outside the uterus. And because it acts like endometrial tissue, it responds to hormones. It bleeds every cycle, and that causes inflammation, scarring, and fibrosis in the pelvis.
Which explains why the symptoms can be so all over the place. I mean, one person could have unbearable pain, and another might only find out because they're having trouble conceiving. So when you're trying to image it, how does it physically show up? What are the categories?
Clinicians usually break it down into three main presentations. The first is what we call superficial endometriosis. These have small implants, mostly on the surface lining of the abdomen, the peritoneum.
And these are the ones that are almost impossible to see on a scanner.
Correct. Very hard to spot. Then you have deep endometriosis, or DE. This is where the tissue has actually infiltrated or embedded itself deep into other structures, like the bowel, the bladder, the ligaments.
That sounds like the really aggressive form that needs careful surgical planning.
It is. And finally, you have the endometrioma.
The ovarian presentation.
Right. It's a cyst that forms inside an ovary, and it's filled with old accumulated blood from that cyclical bleeding.
Okay, so let's circle back to that 6.7-year delay. The sources draw a really stark line between these specialized, dedicated scans and what happens, every day in a community clinic. Why do routine scans, both US and MRI, so often miss deep endometriosis?
It's because a routine protocol is it's not looking for it. It's designed to find common, larger issues. It doesn't include the specific techniques or the patient prep you need to get a clear view of these often tiny, tethered areas. And study after study shows they perform much, much worse than dedicated protocols. So the patient gets a routine scan, it comes back normal, and the diagnostic clock just keeps on ticking.
So the goal isn't just better machines, but making that first routine scan much more sensitive. Okay, let's get to the modality showdown. You said US uses sound waves, MRI uses magnets. What's the key difference in how they work?
The big strength of transvaginal ultrasound, or TVUS, is its proximity. The probe is very close to the pelvic organs, so it can use high-frequency sound waves to get incredible spatial resolution. The upsides are obvious. It's cheap, it's fast, there's no radiation, and it's widely available.
MRI.
MRI uses a powerful magnet to align protons in your body's water molecules. Then it uses radio waves to knock them out of alignment. As they relax back, they give off signals that a computer turns into a very detailed image. Its huge advantage, clinically, is the large field of view, the FOV. You can see the entire pelvis in one go.
Okay, and this is where the human element comes in and just changes everything. The sources hammer this point home. US is hugely operator dependent. How can the overall numbers be so similar if there's such a massive swing in performance?
That's the critical constraint, as you said. The effectiveness of ultrasound hinges entirely on the skill and the experience of the person performing the exam.
Yeah, you see that one outlier study mentioned in the material where this single expert who had done over 10,000 of these exams, got a 98.1% sensitivity. That's practically perfect.
It is. It shows what the technology is capable of in the right hands. But then you contrast that with other studies where a routine US done by a technologist might not even hit 30% sensitivity for deep disease.
But hold on, if that level of skill is so rare, isn't recommending dedicated US kind of a structural problem? It sounds like most people won't get a good diagnosis unless they're lucky enough to live near one of these experts.
That's a really fair point, and it gets to the heart of how we bridge that skill gap, which we'll get to. But to see why that expertise matters so much, you have to look at what the expert is doing differently. They're using what are called dynamic maneuvers.
It's a dynamic maneuver. Give me an example.
The classic one is called the sliding sign. The sonographer uses the ultrasound probe to apply gentle pressure to the organs. Normally, the uterus, the bowel, the bladder, they should all slide freely past each other. If they're stuck together, tethered by endometriosis and scar tissue, they don't slide. An expert sees that lack of movement in real time.
And that's something MRI just can't do because you're lying perfectly still, right?
Exactly. MRI is a static picture. On top of that, for dedicated TVUS, especially for looking at the bowel, the patient needs specific preparation, often a full bowel prep.
Why is that so important for the ultrasound?
Because gas and stool in the rectum create what's called acoustic shadowing. It's like trying to see through a foggy window. By clearing the bowel, the sonographer gets a crystal clear path for the sound waves, which is vital for seeing if a nodule is just touching the bowel or if it has actually invaded the wall.
Okay, so US, fast, cheap, dynamic, high resolution, but totally dependent on the operator and limited by its field of view. What happens if the disease isn't right in front of the probe?
And that's its fundamental weakness. If the disease is high up on the pelvic sidewall or in what we call extraperitoneal spaces, the US just can't see it well, or at all. And that is where MRI's large field of view becomes absolutely essential.
Got it. So let's switch to MRI. Besides that big picture view, what are its other main strengths for staging endometriosis?
Well, it's just superior for that comprehensive staging. It maps the whole pelvis.
Yeah.
But it's also multiparametric. It uses different imaging sequences like T1 and T2 weighted images that are fantastic for characterizing the tissue. They can clearly identify the blood products inside these lesions, which helps distinguish endometriosis from other things, like certain ovarian tumors.
Does a dedicated MRI need special patient prep too, like the ultrasound?
Oh, yes. To get those high-quality images, you do. The protocols usually involve giving the patient an antiperistaltic agent, a drug, to slow down the bowel's movement, which reduces motion blur. They also often use a vaginal gel to outline the structures better and make sure the bladder is half full. Without that prep, the image quality really suffers.
And its biggest weakness, besides the high cost and the long scan time?
Interreader variability. Just like with US, having a great picture isn't enough. The radiologist reading the scan has to have the expertise to spot the subtle signs of deep endometriosis. The same dependency on specialized skill applies.
Okay, so now for the anatomical scorecard. Let's break the pelvis down into those three compartments, anterior, middle, and posterior. Where does each one shine?
Right, let's start with the middle compartment, specifically with endometriomas, those ovarian cysts. Interestingly, US actually had a slight edge here.
Really?
Yep. The weighted mean sensitivity for detecting them was about 77.5% for US and only 67.8% for MRI.
Wow, that's a nearly 10% advantage for the faster, cheaper tool. That's a big win for US for a very common presentation.
It is. It just shows how good that high resolution is on a structure that's right there, next to the probe. Now, let's move to the area with the biggest surgical implications. Deep endometriosis in the bowel wall, which is in the posterior compartment.
And you said the detection rates here were basically a tie, so what's the tiebreaker?
The detection sensitivities were pretty comparable, yeah. US was at 73.7% and MRI at 68.6%. But the tiebreaker is the level of detail. TVUS was shown to be significantly more accurate at identifying the depth of invasion into the bowel wall.
Why is knowing the exact layer of tissue invasion so critical for the surgeon?
Because it completely changes the surgery. I mean, the bowel wall has several layers. If the endometriosis is only on the serosa, the outer layer, a surgeon can often just shave or scrape it off. It's a less invasive procedure.
But if it goes deeper?
If that nodule has gone into the muscularis propria, the muscle layer of the bowel, then just shaving it off means you're likely to leave disease behind. To treat that effectively, the surgeon often has to do a bowel resection. They have to cut out that segment of the bowel and reattach the ends. It's a much higher risk surgery with a longer recovery.
And the sources said that dedicated TVUS was something like 97.5% sensitive for seeing if it got into that muscle layer. That's surgical grade information.
It's gold. It's exactly what the surgeon needs to know before they operate.
The clinical example you provided illustrates this perfectly. So there was a patient, the dedicated MRI was done first. What did it find?
Yes, the MRI was used as the big picture staging tool. It did a great job. It found a deep implant on the vaginal wall that was clearly touching the rectum. So DE was confirmed. But the MRI couldn't say for sure how deep that implant went into the rectal wall at that point of contact.
So the surgical team didn't know if they needed to plan for that major bowel resection. What did they do next?
They played to the strengths of the other modality. They did a follow-up dedicated TVUS with the bowel prep. And that high-resolution view from the ultrasound confirmed the location. But critically, it showed that the nodule was only on the outer layer, the serosa. It had not invaded the muscularis.
Wow. So that single piece of information from the U.S. completely changed the surgical plan. The surgeon could go in confidently, planning for a less invasive dissection, avoiding the risks and recovery of a bowel resection. That's the definition of a synergistic approach.
It is. It shows that for these complex cases, neither one is enough on its own. They cover each other's blind spots.
And speaking of blind spots, let's talk about the one area where MRI is the clear, undisputed winner. That disease that's far away from the center, the pelvic sidewall, and extraperitoneal disease.
This is where the small field of view of ultrasound is an absolute limitation. The probe just can't see those areas well. The data showed U.S. sensitivity for sidewall disease could be as low as 15.4%. So for a complete surgical map, MRI is non-negotiable. It ensures the surgeon knows the full extent of the disease before they ever make an incision.
And just to close the loop on the three types, what about superficial endometriosis, those tiny surface lesions?
Still a blind spot for both, really. Neither US nor MRI can reliably pick those up. That diagnosis often still requires a laparoscopy to see them directly.
So if the top-line comparison is basically a tie that's decided by expertise, what's the best practice recommendation for our listener?
The primary recommendation is actually very simple. Go with the best local expertise you can find. A brilliantly performed, dedicated ultrasound is always better than a poorly done, routine MRI and vice versa.
Okay, let's say you're in a center that has experts in both. What's the ideal sequence to get the best outcome?
The ideal sequence is that two-step synergistic approach we just described. Step 1, start with a dedicated pelvic MRI. That's your wide-angle, comprehensive staging tool. It gives you the full map and crucially finds any disease the U.S. would miss on the sidewalls.
Get the big picture first.
Exactly. Then, step 2, follow up with a dedicated US. Use its high-resolution power to zoom in on specific areas of concern, especially in the back, to get that fine print detail, like the exact depth of bowel invasion.
So it seems like the specialized centers have kind of solved the technical puzzle, but we keep coming back to that huge bottleneck, the 6.7-year delay caused by the low sensitivity of routine scans out in the community.
And that's really the heart of the problem on a global scale. The symptoms are just too nonspecific to rely on alone. So that first line of imaging fails, patients get stuck in that cycle of suffering and ineffective treatments.
This is where the sources offer a bit of hope, though. It sounds like getting good at the focused U.S. techniques for endometriosis, the sliding sign, checking the right spots, it doesn't necessarily take a lifetime to learn.
That's the key finding for future research, I think. The studies suggested that trainees could get proficient after just 25 to 66 supervised exams. That's something you could potentially do in a couple of weeks.
So we're not talking about needing decades of experience for every single provider. We're talking about adding targeted, high-yield training that could be validated and implemented much more widely.
Exactly. If we can prove that adding just a few of these high-yield maneuvers to every routine pelvic US is feasible, that's the patient's first stop, that could dramatically cut down the failure rate of that initial diagnosis, which is what's driving that 7-year wait.
So to wrap it all up, the battle between ultrasound and MRI isn't a tech competition, it's a strategic alliance. The winner is decided by local expertise and the specific question you're asking. For the full picture, MRI gives you the wide-angle context, and US gives you that critical, microscopic detail, especially for the bowel.
And that really leads us to our final provocative thought for you. If the single biggest failure point in endometriosis care is the poor performance of that very first routine scan a patient gets, what if we shifted the focus of innovation entirely? What if the fastest way to end that 6.7-year delay isn't building more super specialized centers, but validating simple training programs that allow every technologist and gynecologist in every community hospital to reliably perform just 2 or 3 of these high-yield endometriosis-focused maneuvers? It might just be the simplest educational fix that could change millions of lives.
A powerful thought to end on. Knowing which tool to use for which job is the key to a faster, more accurate diagnosis. Thank you for joining us for the deep dive.